I would have a comment and a question. To my understanding, it pretty much looks as a very modern tool for reference. Like when I practice in my office, I have guidance books like the MoM, for example, for mental health problems, and a medicine book when it's connecting, interfacing with a medical condition. So in a way, you can ditch those books or put them in a shelf and access the most up-to-date evidence-based information from your computer. That's correct. But it doesn't seem though to record or audit our practice. Like there are clinicians that will always cross-refer their practice against evidence. Some will probably be less keen to do that. So you can't really know if the people are applying or practicing according to standards. Like if it would be to use the map of medicine for bipolar, which is my interest, you will not be able to extract data from your local population to say there are that many clients treated with the map of medicine using that medication or that received that psychosocial intervention. So it's not an audit tool. It doesn't report or feedback audit data to your organizations.
No, you're quite right. But remember, the purpose of the map is to say, here are evidence-based patient pathways. So this is the evidence-based saying this is how we should assess, manage, and treat someone with bipolar disorder. Once you've implemented that and trained everybody and said, this is how we want to change things, and that might be based, by the way, on an audit that you've already done that suggests that actually the care that we're delivering in, say, bipolar disorder may not be as best as it could be, you can then start to think about, well, what criteria are we going to use in the audit? And that's where you could use the map. And in fact, commissioners and providers could turn around and agree and say, these are the specific criteria that we now want to audit, and then perhaps look at over a 12-month, 24-month period to see whether how many of our patients are getting the best care possible. If they're not, why not? And there will be cases where that doesn't happen and it's quite appropriate. But if it isn't, and there is a lack of knowledge or something, then there's an opportunity to then start to train the workforce in terms of it. So it supports audit, it doesn't replace audit policy.
And the other part is obviously like people will put a lot of care in developing a sexy tool. Like now just the monthly people are going around because they sell their books £60 a piece. How is that funded, your tool?
Do you mean the map of medicine?
Yeah, where do you make your money?
Where do you make money? Where does, sorry, I'm not the map. Do you mean where does Mike's team make money?
I get paid as an NHS consultant, but effectively the map's owned by the Hearst Corporation. It's contracted centrally through the local service providers in the 5 different regions of England. We happen to get lucky in that we managed to persuade clinical leaders in all the 5 regions about 4 years ago that this was an important tool to have across the whole of the NHS. And so independently each region procured or licensed the map, and therefore we then, in reverse, we already had all regions, actually had 4, when we had 4 regions, the government came to us and said, we don't want you being the monopoly in the monopoly, and then we signed a national contract and there's an audit mechanism, and it's a very unusual contract, suffice to say, but it's managed by the Hearst Corporation, which is the largest independent publisher in the world that does not for any of its healthcare products accept any kind of pharmaceutical medical device advertising, and it doesn't own or manage any kind of health insurance. So it was the only publisher or media company in the world that could actually satisfy the requirements of the NHS at a central level. Even, you know, almost all publishers, even the New England Journal accepts advertising, and they recognize it does skew evidence and interpretation of evidence, and the editorial policies do get skewed. So the map avoids all of that by being owned and governed by Hearst in collaboration with the NHS.
For our organization, CWP, would be to support widely. Would we have to pay a membership for the map of medicine, or is it already cost and it's using?
But put it another way, the NHS has already paid for it.
Yeah,
so access to desktops and availability in terms of all clinicians in all care settings, whether it's walk-in centres, whether it's district nurses, whether it's A&E, it's not just, it's not licensed. It's not that you've got to pay more money for access to it. There is a cost, however, and I think it's a very important point, and that's the change management stuff. There's a cost to this meeting that the local health community will have paid for to book this room. There's a cost to going out to clinicians to champion what's being said, and perhaps some of the things, I mean, you're the lucky few here who've managed to hear about what the map is. The cost is in you then going back into your own departments and organisations, having those discussions and debates, and saying, what are we doing now? How do we get a pathway that we've worked on, the 5 of us in this room, and get it out there to the hundreds of people that we actually want to use, and ultimately out to the thousands of patients who could benefit from it? And could the map do this? Because actually the NHS has already paid for it.
You mentioned, I think, 350 pathways, which seems quite a big number, but for those of us in secondary care, I mean, I'm a child and adolescent psychiatrist, the number of pathways that would be relevant to me would be quite small. Is it the case that in terms of locally adapting a pathway, there needs to be a national pathway to start with? And if so, where do they come from? Do they always follow a nice guidance thing that then there's a working party that says, let's make a map call from this? So it's led by NICE. So if NICE aren't looking at it, or there isn't enough evidence for NICE to make any strong guidance, it's unlikely it's going to appear on the map.
It's not led by NICE. As I'm sure you've all heard now, NHS Evidence is the body that actually, what's the word I'm thinking of, accredits evidence in whichever form it might be. So it's NHS Evidence, and at the moment, NHS Evidence is accrediting the evidence behind the map of medicine as we speak. Is that right?
Yeah, that's correct, yeah.
Yeah, so it's NHS Evidence, the key body, that's there to accredit all forms of evidence, whichever knowledge tool that you go to. However, the important point is that as local clinicians, you could sit down, gather people together around a table with a blank sheet of paper and say, right, we want to review how we are doing childhood depression, for instance. And go away and spend hours and hours and hours trying to identify what the evidence is, and then trying to gather it all together. Or you could bypass that first bit, and it is the first bit of the discussion, where we say, well, let's look at the map of medicine to see what they've got. Let's see how it feels to us, and then let's bring in any further.
So what if there's nothing on the map of medicine about the area we're interested in? That's the first step. Who kicks that off?
Right. If there isn't something there, then my suggestion would be for you to bring it to us, bring it to myself or James Walker, who's the managerial lead. There is the hand up. Where at the SHA, we can then look at whether there's something there that needs to be developed and whether we need to put further support into it.
And we can also to do that. Sorry. Is there a sort of contact us?
Yes. Yeah. Oh yeah. My contact details are here, and so is James's. And then we can also have that discussion with the MAPA themselves to say, have you heard about this in other areas as well? Is there any other work going around? So that we can facilitate that discussion.
I think it's worth adding that on the map, if you go to the back, there's functionality that shows where people have changed it, and there is so it's other views of the map, and it's on where there is another view, you'll see a node, a new node appear that says, oh, there's other view. You can click that and then look at who's done what. About 250 local views have been put on the map so far. It's obviously growing all the time. And the cost, if you like, to the map to do a part of the 800 hours is over £30,000 a go. So if there is a map, if the cost to localize and review, it's about an order of magnitude less cost to the local organization. But if there isn't one and you want to go ahead and create one, you just need to contact your local organization.